Okay, good. So on the previous lesson, just a quick revision, we spoke about pediatrics state exam, that we need anthropometry and specific signs and symptoms for your patient. We explained this in the previous video. We have different examiners, so we must know our theory well, and as well as some diseases very well. And the diseases must be common and well discussed in the lectures. So if you follow this, you will end up in your exam with like a paper, a bit of theory on the top, like as an introduction, like understanding values you memorized, and then on the bottom you just write one question, one disease very well. So know like one disease for each topic very well. Then just two other diseases that you will mention, because they will ask you, tell me, choose three diseases, and maybe they don't like the first one, they want to jump to the second or third. And then for the rest, just some basics. Just don't memorize like maybe two, three bullet points for it, just what it is. And on the side, the first thing you do in your exam, you write your anthropometry page. So this should be very fast, like 1-2 minutes. You should memorize this and be able to reproduce the anthropometry paper very, very fast. Okay, so we talked about puberty physiology last time, so now let's go to pathology. As a revision, adolescence is like thinking as an adult, and puberty is the physical changes, so ability to reproduce. Uh, and this is the super summary, the check summary that they will give you, comparing girls and boys. We discussed them last time. And now let's go to adolescence, which we didn't have time last time to discuss. So behavioral changes, okay? So this is what is adolescence about. It's about changing the way you think and the way you interact emotionally and psychosocially. So emotions, intellectuality, and society, okay? So these three things is the way to think. And from your psychology, you should know that basically it's the age to find the identity, okay? Values, self-criticism, blah, blah, blah. So identity. And if you fail to find your identity in the society, you have something called socio-pathological phenomena. So this term here is the good way of saying that someone is not a good person in the society. So he does like vandalism and things like that. So the way you say, you don't say to the other guy, you are retarded because it's too aggressive. You just say you are mentally handicapped. The same way for adolescents who have these risky behaviors, we call them sociopathological phenomena in the Czech law. Okay. Adolescents, it's from 10 to 19 years old, and we have to explain a bit how the brain develops. So that's why we have to split them into early, middle, and late adolescence. From the early adolescence, we have these changes, and the result is that they are difficult to interview. Okay, so you ask the child like, "Are you having fun in school?" And he will give you one word answers like yes, no. So they don't know how to discuss their problem, like yes and no, I'm getting bullied. I have some problems with eating. I don't know what's happening with my body. I'm having big breasts, or I don't have big breasts while my classmates have. They will not say this. So they're difficult to interview, and our job is to first create some rapport with them. And since this age, maybe we can start to have like direct from them history, so alone, but also indirect, so the parent is there. So we try to find a way to get the information from them. That's our history. Then we enter the middle adolescence, so that's 14 to 16. That's when the high risk behaviors start. So this is the age where the problems start to manifest. That's why from above 15, let's say, these ages over here, they are going to be more high risk, like 10 times or 20 times more to have like addiction and drugs like this, while the early children, they will not have these problems. So middle, we have some abstract thinking. They are now more sophisticated. So if you say they start to have abstract thinking, that's wrong, because we already have it since 5 years old, and abstract thinking allows school education. That's why the preschoolers cannot go to school. They need to have abstract thinking. The abstract thinking to adolescents is basically more sophisticated. So they can lie, they can enter other people's shoes, so they're smarter, let's say, in a way to be able to lie better and understand how to get what they want. Yeah, so they have some introspection, they're proud of themselves, overlook other adults, and then they have the high risk behaviors. So our exam, it's called high risk behaviors, the final exam question, is basically about this over here, like the middle adolescence, so 15 years old and above. And why is it dangerous? Because we have like accidents, suicide, murder, so it affects the health as well, and we are doctors. And then we have the late one. So the late adolescence is the age where they become adults. So they think about the consequences of their actions, and maybe they stop to do the drugs, they stop to be aggressive, they start driving safer, egocentrism goes away, and they have like morals and values. They know what is good and bad. So the high risk is from 15 and above, and by this age, the high risk behavior should start to subside. Any questions for this?
Stelios,
Yes.
is this applicable in physiological cases, right? This is not pathological.
This is the normal development,
Okay.
but the risk is here in middle. So some of them will do, some of them will not do. It depends on the risk factors, which we'll mention after. Okay. So syndrome of risk behavior is the pathology. So this is the normal development. They start to, in the beginning, have some concerns. They change the way you interview them, and then slowly they start to develop these, let's say, features that predispose them to high risk behaviors. Not necessarily participate in it, but they are predisposed. Okay, so this age and point of development is a risk factor, let's say, and then later it's basically subsiding. So this is the normal physiological maturation.
Okay, thank you.
Okay, so syndrome of risk behavior. Have you heard about it? Yes, I just talk about it now. Okay, let's move on, not waste time. So basically, there are behaviors that have negative impact on development. So the individual patient, let's say the individual child, if they're doing like drugs or they're addicted to something or they have sexual things, then they will have their health, like diseases, or their social and psychology. So maybe low grades in school due to their behavior, and this is development of the specific child. But morbidity and mortality will be for them as well as their classmates, as well as the entire society. Okay, so poisoning, alcohol, drugs overdose, that's for them. Suicide, that's for them. Accidents, traumatic injury, like road traffic accidents, that's for the society as well, and also their classmates and the social environment. So we're all affected by their actions, vandalism, graffiti. So it's not just about the specific patient, but also about the society in general. That's why we call it sociopathological phenomenon. So society is affected, okay? So that's the risk behavior, syndrome of risk behavior. And we have different types of them, okay? So these three types. So let's go through each type and discuss some details about them. So the first one is substance abuse and addictions. So can you tell me what is being abused? What are the adolescents addicted to what? What do you think?
Alcohol, drugs,
Alcohol, drugs, what else?
Cigarette
Yeah.
smoking.
Cigarette smoking, what else?
Gaming.
What?
Gaming.
Okay,
Yeah.
yes, this is what I was waiting to hear. So Professor Zeman, he likes to emphasize that it's not just substances, there's also some behaviors. So gambling as well, video games, so don't forget your behaviors, okay? Addiction, gambling, video games, this behavior also have similar manifestations. For example, someone who is drinking or smoking all the time or doing drugs, they will not be hungry, right? But the same thing with video games. Like the mother will say, Honza, come down to eat some food, but he will say, no, one more game, 1 more hour. And they will stay there and they will lose weight, cachexia, and bad hygiene. So basically, behaviors, they have similar manifestation on your physical examining history as some addiction. So he may look like he's doing some drugs, like losing weight, bad hygiene, bad grades, like he's a bad adolescent, let's say he's doing the risky behavior. But actually, if you dig through the history, you find out that he has nothing in his blood that suggests that he's doing some drugs. So substance abuse and addictions is not just substances, it's also behaviors, okay? And this is what Professor Zeman likes to ask. Video games, for him, it's a number one. So he's very old, so he saw the introduction of technology, and he saw and realized the negative effects that video games have on adolescents. Okay, so don't forget your video games, don't forget your behaviors. Okay, and gambling as well. So then this is some statistics, other things in Czech Republic you can read it on your own time. So you said correctly, like smoking, marijuana, alcohol as well, and some other illegal drugs. But yes, Riram was right. Don't forget your video games and behaviors. Symptoms, so non-specific, emotional personality changes, depression, mood swings, social problems, school performance and attendance. So as you can see, this line is also in video games, not just drugs. And then physical changes, fatigue, weight loss, eating habits, also in video games. They will not eat, they will stay up all night, they will not study. Uh, Not sleeping makes depression and mood effects. So video games as well will have these symptoms, okay? Not just your drugs. So keep in mind, if you see an adolescent, also ask, do you play video games? Do you sleep late at night? Do you play games all night with your friends? Then specific, that's your things that you're going to see in your physical exam, like pupil constriction, that's your drugs, venipuncture marks, that's your IV drugs, and dental hygiene worsening, also like not taking care of themselves. And then we have some symptoms of addiction. So difficulty controlling use, steals money for it. For example, also video games. They cannot stop. They stay up all night. Maybe if they play online service that they have to pay every month, they will try to steal some money to pay for it. So it's not just drugs, okay? Tolerance, more amount for the same effect. They used to play 1 hour, now they play 10 hours and they still don't feel happy for the video games. Withdrawal symptoms, agitation, tremor. So this is for the drugs, but agitation, for example, if the father comes and closes down the computer while the child is playing, he may become aggressive, break the screen, break the computer, attack the father. So also don't forget your video games and behaviors, okay? Gambling as well. So not just substances. I want to stick this into your brain, also behaviors, okay? Diagnosis for abuse, okay? So this is not a diagnosis you're going to make for the general risk behavior, is diagnosis for this specific type of risky behavior. So we try to do some screening and prevention at school age, okay? So we try to prevent them from it. Adolescents, it's higher school, but we try to do it at school age. So this is before your adolescence. And we also have some doctor. It's recently introduced into the health sector. As we said, gain the trust. I'm your friend, some empathy. Make the interview as friendly as possible. Get your report so you can get more information from them, okay? Because we said they are difficult to interview. We need to give some clear recommendations for the change. Don't just say this is bad, just say, okay, I understand like this makes negative effect, but what you should do instead, and explain them what to do. So it's easier to tell someone what to do than what not to do. Educate them about the harmful effects, and then this requires some level of development, okay? So we need to have a specific age that they can understand the consequences. So that's your middle adolescence, middle and late. And then we have some questionnaires, okay? So ICD-10, that's the WHO international one. But in Czech Republic, we use the CRAFT questionnaire. CRAFT comes up in your credit test. The Czech parallel have to write it down. Like the question in the Czech parallel credit test is write down at least 2 questions from the CRAFT. While ours, the English parallel, I think it's multiple choice. So you just choose which questions are CRAFT and which questions are not CRAFT. Basically, it's 6 things, CRAFFT. These are 6 things that you should know for your exam. And Honzik asks this in the exam. Tell me all the craft questions. So anyway, you need to learn everything for the exam, and it will help you in the credit test as well. What does it mean? Like car, for example, means have you or someone else been in a car while being high or while consuming alcohol? So that's one point. It's very, very simple questions. Then relax. Have you taken alcohol or drugs to fit in or to relax? So this is your second question. And then third question, alone. Have you taken alcohol or drugs alone? Forget. Have you forgotten something while using the drugs? Have you forgotten like blackout, let's say? So this is your indication for overdose, like they cannot control it. Family and friends. Have your family and friends tell you to cut down on this, like video games or smoking? And then the final one is travel. have you gotten in trouble while using these drugs or playing video games, let's say in class or something? So this is your craft, okay? 6 things. 2 yes warrants further evaluation. So 0 to 2 is no abuse. It's normal to have 2 of them. They're adolescents. It's not their fault maybe, or it's during the peer pressure. So it doesn't warrant abuse. But 5 to 6 warrants abuse. Okay, that's the diagnosis for abuse. If they're doing everything, it means that they're abusing it. They're addicted to it. In between, it's like high risk to go to abuse. So above 2, number 3 and above, we start to evaluate further. Okay. Then we have the second category, sexual risky behavior. Can you tell me some examples of sexual risky behaviors, and what is sexual risky behavior a risk factor for? What do they get when they do sexual risky behavior?
HPV.
Okay, so sexually transmitted disease. That's risk factor 4. Anything else that sexual risky behavior can lead to?
I don't know, maybe choking or something like some risky sexual behavior.
Okay. What I was looking for, I think, was pregnancy, unwanted pregnancy,
Okay.
and some examples of behaviors that are considered sexually risky.
Not using condoms or protection.
Okay, unprotected sex. What else?
Sex under the influence of drugs or alcohol.
Okay, yes. So don't forget early coitarchy. Okay, so early coitarchy. When they start to have sex at a younger age, the coitarchy is like the first age, the losing your virginity, basically. If you have it at early, then you are risk factors for all of these things. Okay, STDs, unwanted pregnancy, multiple partners as well. And yeah, unprotected sex, you just said this. So STDs, unwanted pregnancy. If you have early coitarchy, you have frequent partner change. Okay, so when they start to have sex younger age, they are predisposed to learn to change partners. Okay, then the last one is psychosocial risky behavior. Do you know some examples of these things, and what is the most important in this category that we need to be aware of? Let's say highest morbidity, highest mortality. Any idea?
I thought
What?
suicide.
Suicide, yes. Okay, that's correct. Yeah. So autoaggression, suicide. Okay, that's the most important one. As we said, 15 to 19, that's the ages where they start to be influenced a lot and start to have the high risk behavior. So that's why the younger ages don't have so much of it. It's 10 times higher from 15 and above. Okay. So remember your physiological development of the brain of adolescents, that when you reach the middle, then you start to have the high risk behaviors, not earlier. Okay. It could happen, but it's most common from the middle and above. Okay. So that was the auto aggression. So themselves, they can cut themselves, they can harm themselves, or maybe also eating disorders. That's considered also auto aggression. And suicide is like the most important in this category. We also have interpersonal, so that's the bullying, like making cliques as well. So in between the adolescents. And then the last 3 things is affecting society. That's why it's called psychosocial. So we have the driving, delinquency, that's a minor crime, like vandalism, theft, graffiti, blah, blah, blah. And also school absences, performance, that's affecting them, but it's also affecting the society later on when they graduate. They cannot find a job, and maybe they have some criminal careers and stuff like that. So etiology for the risky behaviors, we said identity, they cannot find their identity. So that's the stage for adolescents. You need to find your identity, who you are, make your values. And if you fail to find your identity, then you have the sociopathological phenomena. That's the pathophysiology. And then we have risk factors. Remember the age and protective factors. Okay, so if you are educated, you have good peers, as opposed to having like bad peers, or the legislation. So if you live in a very strict country, it's difficult to get them. So it's difficult to do these things. And yeah, risk factors, you can read them by yourself. And then we have diagnosis. Okay, so we said craft is only for drugs. Okay, like it's the abuse, and you should know the 6 things of craft. But Honzik asks for both. He asks you, okay, tell me about heads and tell me about craft. So the history, we said direct, so alone, and also indirect, the parents of the adolescent. So we need to take both. And then we need to know, what does heads mean? Okay, so this is basically categories. It's like the anamnesa, categories you should talk about. And this is specifically the 6-step questionnaire. So home and family, what is happening at home, in the family? Are they using drugs themselves because this is a risk factor for having risky behavior? Education, employment, eating behavior. So has anything changed? Any risk factors there? Activity, sports, social and friends. So what are they doing if they're not at school? Are they going to a computer cafe, or are they going in a ghetto or a bar? So risk factors there. Affect mood and behavior. So this is the symptoms, right? So has it changed the mood? Has it changed the behavior? Have they stopped going to school and stuff? So this is also the symptoms, not so much the risk factors. Drugs, we talk about the craft. Then sex, you should ask about the coitarche to see if they are already active. And they also, how is their behavior? Are they using condoms? Do they have only one partner? Sleep, so that's the second S. So there's 3 S's. So sleep, are they sleeping well? Because we said if they don't sleep well, they have mood problems, depression problems. The brain needs to sleep to grow, develop, and restock on the neurotransmitters. And then also suicide, self-harm. This is the screening, let's say. Do you have suicidal thoughts? Have you self-harmed yourself before? Any suicide attempts? So it will put them on high risk for the psychosocial category of high risk behaviors. This is like more detailed points. Physical exam, we see the anthropometry, anything on the skin, something that can show us that they're doing drugs, the effects of drugs, effects of withdrawal. And then if you suspect drugs, you can do the toxicology, okay? So there is blood, urine, and now we have also breath, so breath analyzers for screening. So that's how we make our diagnosis for the high-risk behaviors. And then the treatment, we have like all adolescents, like what the society can do, that's school-based or community-based, but we also have the individual, like the specific child, something to him by himself, something to a family of the affected child, and also exercise. So if they are doing exercise, they have less time to be bored, okay, and less depression as well. Not excessive exercise, because that could lead problems to puberty, but the normal amount of exercise. So society, what we can do for all of them, and individual for the specific patient. Okay. Any questions for adolescence pathology? Then we go to puberty again.
For me, no.
Okay, so no questions for adolescents. Let's go to puberty now. So this is Latin. Going back to your first year, what is tarta and what is precox? What is tarta?
Tarda is late.
Late, and precox?
It's like premature, maybe.
Yes, so tarda is delayed and precox is precocious or early onset, okay? So if you speak in Latin terms like the Czechs, they will say pubertas precox and pubertas tarda, okay? So remember your Latin, don't get confused in the lessons. And then revision from our previous, what is normal puberty? So how do you define normal puberty? Not delayed, not early?
Like primary and secondary characteristics, right?
Yes, okay, so that's the physical changes. That's the first thing. We have to classify the physical changes. And the second thing?
Gonadarchy, adrenarchy, and...
Yeah, so the age. Good. Yeah. So we have the timing, early versus delayed, and also physical changes, okay, depending on what you said, depending on which hormonal axis is activated. This is not the adolescence. Remember, adolescence is psychosocial development of the brain, not the body, okay, not the reproductive part of the body. And then again, revision from before, what centile corresponds to 2 standard deviations? Minus and plus 2 standard deviations, so 2 centiles.
97 and 3.
Yes, so 97 and 3, good. So moving 2 standard deviations, that's down, that's your 3rd centile, and moving 2 up, that's your 97. And we gave this example last time that you have to know how to draw 3, 10, 25, 50, 75, 90, and 97. So that's our centile, okay? So this is an example of the weight, but it can be used for everything, okay? The centiles. So let's start first with the delayed, okay? Pubertas tarda. What is the definition? And when we say family history in puberty, what do we have to ask for puberty?
Delayed puberty, right? Like puberty doesn't start at maybe primary development or secondary development is postponed.
Yes, but we said we have to use standard deviation. So how many standard deviations?
Greater than 2 standard deviations.
Exactly. And then for both genders, it's 2 standard deviations. But then we have age difference, okay? So who gets the puberty first, girls or males?
Girls.
Girls. And how long after the boys?
1 year.
1 year, yes, remember, 1 year. Boys are always 1 year later. And what do we say? What do we ask about family history? What do we have to ask about puberty?
When
About
was
their
your
parents.
mother's menopause?
Okay, so like mother's history. Okay, maybe
Sisters.
fathers.
Yeah.
Sisters, brothers, yes, good. So don't forget your sisters and brothers. That's your siblings. As you said, lack of first signs of puberty, that's part of the secondary sex characteristic. At chronological age, more than 2 standard deviations, sometimes they use 2.5, from middle age of puberty, onset for gender. So it depends on gender. And then we take the middle age, and then we jump 2 standard deviations. This means for the girls, no thelarchy or pubic hair by age 13, and for males 1 year later by age 14, the testicular, okay? Remember, your first signs is different for males and females. This is more common in boys, okay? So boys, not only they get it 1 year later, but they're also higher risk of having delayed puberty, okay? So remember that delayed puberty is more common in boys. And what is stalled puberty? What is this term, stalled puberty? Not delayed, but stalled. Have you heard?
Puberty stopped at a particular point, like it stops, the process stops, yeah.
Exactly, yes. So it means that they start to get the first signs. So it's not delayed because they have the first signs. Delayed means they don't have the first signs of puberty. So stalled means that they have the first signs of puberty, but then the development stopped, okay? And the actual definition is 5 years since onset. So first signs of puberty happened, but then stopped developing 5 years since onset, okay? So they're already developing for 5 years, then they stop. Okay, that's your stalled puberty definition. Moving on, we said siblings, don't forget your siblings, okay? And then some specific onsets of all these things, period, duration, how long did it take to complete the transformation? The course, was it stalled? Is it a late boomer? Is it complete or isolated? Anthropometry. Anthropometry, we need to find the mid-parental height, okay? And also proportionality, if the legs and torso and arms are growing in proportions, okay? Not disproportionate, because that's pathology. And then any other pathologies which affect growth of puberty. Why growth? We're talking about puberty, but why growth as well?
Because they grow taller, and do you mean like this?
Exactly, yes. Like humans are the only animals that they have a childhood period, while all the animals, they just grow. So growth, when you look at the puberty pathologies, one of the axes we said is growth hormone. So we have gonadal, adrenal, and growth hormone. So maybe the growth problem is actually due to a pathology affecting growth and not puberty. Or it could be a pathology of puberty that affects growth. So we need to know both, okay? 2 categories, puberty and growth. We're going to do them in another seminar. Any other genetics or sex development disorders and things, okay? That's the things we need to ask. And then what is the most common cause of delayed puberty? We said that it's in boys. Delayed puberty is most common in boys, right? And since it's most common in boys, then it becomes the most common in general, okay? So the most common cause in boys, most common cause of puberty delayed in general, but it is also the second most common cause of short stature. So that's your growth disorder. So this disease is going to affect growth as well, okay? So it's affecting growth and puberty. So what disease could that be? What is the name we give to the most common cause of delayed puberty and growth?
Dwarfism?
Okay, so I'll give you the answer. It's constitutional delay in puberty and growth. Okay, so this is the name of the disease. Puberty and growth, we said it affects both, okay? And it's called constitutional delay. So what happens basically, if you look at osmosis here, it can also be called idiopathic, but we don't like to use idiopathic because it will mix our head when we discuss the differential diagnosis. So we just say constitutional delay of growth and puberty. It's basically some transient dysfunction of GnRH and then just makes slow maturation. Okay, so this is normal development. It's just a variant. It's normal, but because it's more than 2 standard deviations, then we need to put it in pathology. So we give it pathology of delayed puberty, but we know that it's just a normal physiological variant. So we don't need treatment for it. It's due to delayed GnRH, LH, gonadal axis due to some genetics. So this means that we have family history, right? So that's why we take family history as well. It's a physiological variant which is based on genetics. So take your family history. Another name for this is called late bloomers. Okay, so as the flower blooms, in the end they will reach the blooming phase, but they are late to bloom it. Okay, so I will show you the graph later. But it means that late bloomers, in the end, they have normal adult height. Okay, as defined by their genetics. Okay, so genetics and growth is normal. It's normal adult height based on their parents. But what we have is childhood short stature. Okay, all the time that the GnRH is not working, they will remain short. But after, they will catch up. Since the axis is GnRH, and GnRH doesn't play a role in growth in the fetus, they have normal birth length. Okay, everything is normal. GnRH is not delayed there. It's only after, okay, in puberty, the problem. So they have normal birth and normal adult. They are normal. What happens is, like you see here, normal, and here normal. What happens is in between. The problem is in between. Okay, so they have some slow growth rate after birth, about mid-infancy, but it parallels the growth line centile, but at a slower and lower centile. Okay, so you see that they are normal. Then they have very slow, and then it parallels the line. But okay, let's go back. But at the very, like, below third centile. So this is pathology. We said in the first lecture that everything below 3 is considered pathology until proven otherwise. Okay, so normal, but in between we have some slowdown. Okay, this is our growth, but also delayed puberty, because we know that GnRH axis is growth, but as well, no, GnRH is maturation, but puberty is also affected with, it's also related to growth. So GnRH is puberty problem, but leads to growth hormone problem. So that's why we have puberty and growth, okay? This graph shows the growth. It gives emphasis on the growth. Then they catch up, and what we can see on the bone age, we said before on the previous lecture that the sex hormones will fuse the growth plates. So this guy is having less sex hormones, so his bone age is younger, okay? So that's very important, that to be considered normal, we have to see that the bone is still young. So this means that they remain in puberty longer, grow longer, and they finally end up in the normal adult height, okay? So delayed bone age, we have to assess the height based on bone age rather than chronological age. So he will look short for age. You say for your age, because you see the x-axis is age. For your age, you are very short. But when we correct it for the bone age, you are normal. So you are growing normally with your skeleton is growing at a normal, let's say, point, but at different velocities in time. So constitutional delay in puberty and growth, it's GnRH transient physiological genetic variant that will cause the puberty to be delayed, and hence also the growth will be delayed, but the bone age is younger, and eventually they will catch up. Okay, so when we say pathologies of puberty, what we have to be very give our attention to it is the total height in the adults. We want them to be as normal as possible, as physiological, let's say, as possible. So they are socially accepted, their psychology is okay. So when we have problems in puberty, one of the things, okay, we have reproduction, but another thing is also the terminal height, okay? And here we have the orange line, it's what is delayed. So they will not grow, they will not grow. Blue is the precocious puberty, they will start to grow. Black is the normal puberty, they will start to grow later. And finally, the orange line is the delayed puberty. So they will start to grow at a later age. And then they catch up. From this graph, just know that normal, then we have delay, like slow down, and then we have catch up. So constitutional delay in puberty and growth, just know that it's normal in the beginning, normal at the end, mid-infancy slow down, and then catch up at a later age, okay?
Can I ask a question?
Yes, yes.
So this is just a variant and it's not a pathology?
So we said
It's
it's
not-
wait, we said that it's
I'm so confused.
a normal physiological variant, but we defined our pathology based on delayed first signs of puberty, right? So this person is coming to us, he gets the diagnosis of pathology, but then when we do the investigations, which is the bone age, and we see that it's delayed bone age, it's very young, his skeleton, and everything else is, let's say, normal. Then we can say, look, we gave you diagnosis of pathology. That's why we indicated the X-ray of the hand for the bone age. But after our investigations, we found out that you are constitutional delay in puberty and growth, which is a normal variant. So you have to give them diagnosis of pathology at first in order to indicate further testing.
Okay.
So,
And then there is no treatment for it, it's just
No.
waiting.
Exactly. So
Okay.
you do regular every 6 months follow-up to see that actually, so he will come at this point, right? He will come at this point here in the graph because he went below third centile. So he got a diagnosis of pathology, let's say, and he also crossed 2 lines. If you cross 2 lines, then that's pathology again. So he was on the second line and now he's below the second line. So crossing 2 lines is also a pathology. So he's less than third centile. He crossed 2 lines. You are at this point, you have no idea about the future. So you say, look, you are in the pathology definition, and I'm starting the laboratory analysis, the imaging analysis. I'm doing investigations on you. And then you find out that the bone age is younger. And then you say, look, come back every 6 months, not every year or every 2 years. And then you do more regular checkups, and then you see this jump. When you see this jump, you say, okay, my diagnosis was correct. You're going to finish in your actual terminal height. And then you continue following him, you see that he's growing fast, and then you say, okay, finally I was right. It was good that we did no treatment. But if you don't see this going up and you're still going straight, you start to question your diagnosis.
Okay, I understand now. Thank you.
Exactly. So he fulfills the definitions for pathology. But after our investigation, we find out that actually he's normal. We just do follow-up. So this is revision from before. How do we find the predicted adult height? So this is the formula they need in the exam. I don't know why they make it so confusing, and this is the formula they use. But I simplify it like this: mother and father plus or minus 13, depending on the gender. So the taller is the man, so plus for men and minus for women, and then divide by 2. And then what you do, so you will find this calculated number, you just add and remove 8.5 centimeters, so up and down, and that's your third centile and 97th centile. This means that if you have 5 brothers, all of them are male, with the same parents of the same height, they will not all be the same height. So the brothers will be different heights. So this is the range of the males of these specific parents that we are considering normal. So all the brothers should be within here and here, okay? Because this is based on father and mother. And if they are the same and they have plus 13 because all the 5 brothers are males, so plus 13, then they will not all be the exactly same height. You don't see 5 brothers with the same height. They have different heights. So this is a calculated number, and then you add and remove 0.5 centimeters, and you get a range which is normal for the sons of these 2 parents to be in. Okay? Okay for this?
Yes, thank you.
Okay, good. Now let's go to differential diagnosis of constitutional delay in growth and puberty. So we said that it could be a sign of serious disease. We don't know yet. So we have to differentiate if it's actually normal or not. So differential diagnosis, we have familial short stature and idiopathic short stature. That's why we don't use idiopathic, let's say, delay. Osmosis here used idiopathic delay, but we said, look, let's not confuse ourselves because we will confuse the differentials. So important thing is only short stature, right? So only growth, nothing to do with puberty. These two things have nothing to do with puberty, while the previous one is in growth and puberty. So what happens here, let's say familiar short stature, this is easier to explain. It means that it's your genetics, okay? So one or both your parents are short. That's why you enter the pathology, let's say, definition. So you see this patient here, he's below the third line, the third centile. So we can say that this guy is fulfilling the pathology definition. So his pathology, and then which disease, we use familial short stature because one or both his parents are short. So he inherited it. It's his genetics. It's the most common cause of proportional short stature. What is important to do is exclude some unknown autosomal dominant disease in a parent who is short. So if you see a short parent, you expect to have a short child, but let's see, is it due to some pathology or are the genetics like this? Is it normal and the genetics caused him to be short? Or is it some other pathology which can be prevented so the child is taller than the parents? So always when you see a short parent and it causes a short child, always exclude some autosomal dominant disease in the parent who is short, okay? How to differentiate it from the constitutional delay? Bone age. So we said that the bone age in constitutional delay will be younger. So he will be, let's say, 17 years old, but his skeleton will be 15 or 14. So he's younger. But with familial genetic short stature, what happens is that it's his genetics. So the bones follow his genetics. There is no delay, there is no advancement. It's the same age. So also he was short at birth because of his genetics, and he will be short at terminal adult height because it's his genetics. And also there is no slowdown or catch up. He keeps going straight, following the genetic instructions. So puberty is not delayed, only growth. Okay, that's why it's short stature and not short stature and puberty, only short stature. Puberty is fine. We have the bone age, which is proper age, and the slowdown is not visible. It continues always following the line below the third centile, and also he reaches short adult height. So that's the genetics, okay? Familial short stature, always below the line, very short at birth, let's say, very short at terminal height. While constitutional, normal, and then slow down and catch up. And the bone age is younger. You understand the difference between these two? Differential, how to differentiate them?
Yes.
Okay,
I
so
have another question,
yes.
if I may ask. Why is it considered a disease? Is it because of the lower centile?
There is different, let's say, criteria of how to define a disease, okay? So first of all, we have static values. Static values is when you take one measurement at a time. So it's the excess. This is a static, this is static, this is static. So if the static is below the third or above the 97, then it's automatically pathology, okay? So that's the first criterion, the static value. The second criterion is dynamic value. So how it change over time. So you take at least three, I think, at least three, you need at least 3 points to make the change over time, so your dynamic value. And if you see here, for example, he's on the second line, and then you see that over 3 lines or 4 lines, he changed 2 lines. If you change 2 centile lines over the course of your growth, this is a dynamic criterion for pathology as well. He's within the the normal centiles. He's above, until this point, he's above the third, but he changed 2 lines. So this is a dynamic criterion for pathology, while this guy is static criterion for pathology. So you have 2 things: crossing 2 major centile lines as a dynamic value over time, or being below third or above 97 as a static value.
Okay. Thank you.
So I hope I cleared that up. So yes, we're talking about how to define a pathology, and the people who are defined as pathology, they are indicated for further investigations. While someone who is normally growing, you will not do bone age. You will not send him for bone scan, X-ray scan of the hand. So once you get this one of these 2 criteria for pathology, you are allowed by the insurance company to send for investigations, and they will cover it. Okay. While if someone is normal and he's not pathologically, if he wants a hand X-ray and bone age, he has to pay for it. He's doing it by himself. He has no indication for it. And now moving on, idiopathic short stature, again short stature, nothing to do with puberty. It's the same as familial. The graph is the same, but the difference is that it's not familial, it's idiopathic. It means that the parents are not short, okay? And we have to exclude some secondary causes. So it's a diagnosis of exclusion. If you see that he's following the same genetic things, let's say, so bone age is normal with chronological age, he is below the line, growing steadily, he will end up being short. If it's due to short parents, it's familial, and if it's not due to short parents or secondary causes, it's idiopathic. Okay, you understand the difference between familial and idiopathic?
Yes.
Okay, so if I ask you to draw the graph for idiopathic short stature, you will draw the same graph. But you just say the parents are normal, no secondary causes. So it's the same graph and the same bone age. Okay, now how do you make the diagnosis? We said already, take the family history. Usually it's positive. You look at the centiles, you're going to see the slowdown, catch up, normal terminal and normal birth. You do the bone age, yes, we said, to compare it, that it's going to be younger, and then exclude some secondary causes, do some labs, imaging, and everything will be normal. So you do your diagnosis like this. I saw the bone age, it was younger. I saw that it was normal at birth, and he's slowing down, and then he's catching up. Treatment, it is normal, child is healthy, just reassure the parents, and then you have to do some every 6 months, okay? You have to see the expected catch-up, because the moment he comes, you will not have all the dots. He will come at this point where he crossed the 2 lines or where he's below the third centile. So then you have to do 6 months measurements to see this catch-up. Once you see this catch-up, you can relax and say, okay, my diagnosis was correct. Okay, actual pathologies now of puberty. So this is our axis, right? This is our physiology. And then we have primary and secondary. That's your 3rd-year pathology and pathology stuff. Primary means that the gonads are the problem, right? So this is your primary. Gonads are the problem. And you have low testosterone. Then you have your delayed puberty. What happens to the axis above is that they start to be overstimulated because they don't have the negative feedback. In the secondary hypogonadism, the gonads are okay, so they can function. They are just not stimulated by LH, FSH, so it's a problem upstream. So it could be either some hypothalamus problem, that's your GnRH, or it can be a problem of your pituitary, so that's your LH and FSH. Okay, so primary and secondary. You know this from 3rd year. How to classify them? So secondary hypogonadism, it can be some functional. So we have some diseases that can cause this. So it's not genetic, it's not something that happened or acquired. It's some other function. So you have endocrinopathies or some chronic systemic disease, excessive sports as well. So usually women who do excessive sports, they have their coital, their menarche late. Excessive stress, so that's also your psychological. If you are under constant stress and child and abuse, you will have delayed puberty maybe. But also your genetic things and your acquired things, everything that can affect the axis. And then you have your gonads problem. So it can be some genetic, so Klinefelter-Turner, or can be some other thing that affected the gonads, okay? Not the brain, but the gonads, like some autoimmune, some infection like mumps, trauma, torsion of the testes, radiation, cryptorchidism is a risk factor, and some other problems, okay? Also metabolism. So that's your etiology. How do you approach, how do you diagnose it? So always history, following our internal. So history, physical exam, labs, imaging, and special investigations. So history, family history, centiles, Tanner. When we take these values over here on our history, we always need to compare to parents and siblings. So we did the question in the beginning, always siblings, don't forget siblings as well, okay? Any other diseases, some history of the patient, we said the causes, physical exam, again, take your anthropometry, make your Tanner stage. We're talking about puberty, okay? So is it stalled? Did it start? Is it delayed? Then check the nutrition, the risk factors, the etiologies, some chronic diseases, again, etiologies. Neurologic exam as well, for example, for Kalman, or some facial dysmorphias like Turner or Klinefelter, and congenital defects and some other things. So you check for all the possible etiologies and you try to exclude. You are excluding things until you find out the most probable diagnosis. Remember, for pulsatile hormones, this is from a previous lecture, that to interpret them, we need to do some dynamic testing, okay? Stimulation or inhibition. And we have some example here. And GnRH is one of the things that we need dynamic testing, okay? Not testosterone and estradiol, not LH and FSH, but GnRH. When we want to check the GnRH axis upstream, we need to do some dynamic testing. So don't say, I'm going to take the GnRH from the blood. You have to say, I'm going to do a dynamic testing for GnRH. So this is our labs. You do some general test, find some disease, chronic disease. For our hormones, testosterone, FSH, LH can be basal, okay? And we're going to differentiate primary versus secondary problems, okay? So testosterone will be low for both, but LH, FSH, GnRH will be high or low depending if it's primary or secondary. So this will help us differentiate primary or secondary. Some other hormones, some genetics, some autoimmune things. And then moving on to the dynamic test, we said GnRH is dynamic test. So how to differentiate hypothalamus from pituitary? We do the GnRH stimulation. So this is basically, you measure the LH, then you add a GnRH agonist, and then you measure the LH again. If it goes up, it means that we are stimulating this part over here. If it goes up, it means that the pituitary is working fine, and the problem is hypothalamus. If it doesn't go up, it means that we don't know, okay, maybe the hypothalamus is working fine, but the problem is pituitary, okay? So GnRH stimulation, we're checking if the pituitary can be stimulated and each can go up. Why not FSH? Why we don't use FSH? Why do you use LH here for the stimulation?
FSH is also pulsatile, right?
From our previous lecture, we said that FSH is a long-term indicator. So it's like for glycemia, you have hemoglobin A1C. So it's long-term glycemia, let's say. So FSH is long-term GnRH stimulation. So LH follows the short-term fluctuations. So LH is what we use, short-term. We stimulate it, LH will change, while FSH will not change. It will change less. It's affected more by long-term. And then we can say if you do hypothalamus. Imaging, we said bone age of the left hand, some ultrasound of the gonads, head MRI to see some brains in tumor and stuff like that. Treatment, causal, treat the causes, maybe thyroid, nutrition, celiac, or whatever. So you treat the cause if you can find it. For constitutional delay of growth and puberty, we said no treatment, just frequent follow-ups, try to see the catch-up. And if the guy has social or psychological issues and is a male, then maybe we can use some testosterone. We avoid it because testosterone will make the premature closure of the growth plates. But yeah, we can use it for males if needed. And then going to our actual pathologies, what we can do is something called induction of puberty. So this guy or girl is delayed puberty, and we need to make an induction for it. Okay, so it's different between males and females. The males, they take intramuscular testosterone. the females that take estradiol orally. Okay, we start small and we increase the dosages for both. Osmosis have it here, like you increase the dosage slowly. Why do you stop the treatment at a point? Why do we have to stop the treatment for males, testosterone?
It could suppress the innate production.
We said that we don't only care of reproduction and maturation of the secondary characteristics, but also important thing for puberty, not just reproduction and physical changes, but also
Attitude, like also development.
yeah. So terminal height. So height.
Oh, okay.
So we stop it and let him grow. Let him grow. Okay. We don't give growth hormone because it advances the bone age by a lot. Okay. While the testosterone, it will grow slowly without advancing the bone age so much. The strongest effect is by estradiol. Okay. Remember that estradiol is the strongest effect on fusion of the plates. Then we have like when to start it, when to finish it. But for the females, an important thing is that we add progesterone cyclically after doing the estrogen. So we do the estrogen, and after the breast development is beyond the areola, we can add the progesterone to induce menstruation. So we are doing like an artificial cycle, let's say, okay, depending on the cause. So for males, testosterone, increasing dosage, okay, you stop. You can do a second course if needed. But for females, you start with estrogens, and after the breast is big, then you have progesterone for the cycle, because the cycle needs the progesterone to happen, okay? So that's the induction of puberty. It's different between males and females. And selected diseases, what to talk about delayed puberty. We have the constitutional delay in puberty and growth. It's the most common. Is it most common in males or females? Just checking.
In males.
In males, exactly. Then we have the two differential diagnoses. Just know the basics and the drawing, how they differ. Turner, know this very, very well. They always ask Turner. Klinefelter, know it very well. And also maybe Prader-Willi and how it's compared with Angelman syndrome. So they ask what is the difference between Prader-Willi and Angelman syndrome? What's the difference? And then everyone says Kalman because it's in USMLE and osmosis and stuff like that. Know the basics, but they hate it. Don't mention it. Just know there is some disease called Kalman syndrome, which affects also the smelling, is due to migration problems of the olfactory plateau, but they hate it. They don't like, everyone goes there, especially after USMLE, and they say, okay, Kalman syndrome, but they don't like it. So yeah, just know a bit basics, but don't mention it. Mention Turner, Klinefelter, androgen sensitivity, know it well because it's also in sex development disease, and your galactosemia, know this well. They ask it in other questions as well, so you should know how galactosemia affects puberty. These are my notes. I can send them to you if you want. It's all the diseases we mentioned, and the biggest one is Turner, of course. So very well. Prader-Willi, and this is Angelman. So Prader-Willi versus Angelman. Klinefelter, okay, less than Turner. Galactosemia, know the information here, but not as well as Turner. Okay, know what Honzik wants to ask. Androgen sensitivity syndrome, that's from the sex development. And then Kalman, just know a bit of basics and just explain Kalman in basics if they ask. So that's your selected diseases for delayed puberty. Okay, another question. What is infertility and what is sterility? What is the difference?
Is one of them where you don't produce sperms or eggs? So
okay, so you are going down the pathway of what do the gonads do, let's say. What they like to ask in the exam is Turner infertile and is Klinefelter sterile? These two questions they ask in the exam. So you need to know the differences. So you're going to learn the differences, and there is a question for it in gynecology exam. So in gynecology exam, you have assisted reproduction, okay? And you have to know the difference. But they also ask it in pediatrics for these two diseases. The difference is that infertile means that you can, with help, make baby. So the assisted reproduction for gynecologists is only for infertile people. Sterile is that we cannot, with some help, make the baby. So like no matter how much treatment we do, you will not be able to have babies. So you're sterile. So is Turner infertile? Yes, Turner is infertile. He has problem doing naturally babies because the oocyte DNA is not viable, right? But he's not sterile. Like she is not sterile. So Turner syndrome is not sterile because they have a uterus which is working. So we can use some hormones during puberty to mature the uterus, make it a bit bigger, and then the uterus can accept embryo. So what we take is a donor egg, so not the patient's DNA. We take a donor egg, and then we use IVF from the husband's sperm, and then some hormonal stimulation, and then we implant the embryo, and she can make a baby. It will not be her DNA, but it will be her baby that she was carrying 9 months and she gave birth, and it's also the husband's DNA. So then the baby, it will be in the family and it will have zero chance of having Turner. Yeah, so Turner is infertile but not sterile. Now, on the other hand, Klinefelter is sterile, okay? His sperm DNA is not viable, same as like oocyte DNA of Turner, but we cannot make him pregnant. And we cannot take his sperm and by aspiration and make IVF and make a baby. So what I'll ask you is that a guy with Klinefelter came in and his wife is pregnant. What is the problem? The problem is that it's not his. He is not able to make the wife pregnant. So this is like a joke they like to ask, but the point is that no matter what he does, this guy is sterile. He cannot have a baby. So if his wife is pregnant, it's not his. Because there was a patient of Klinefelter that was insisting that the baby was his and that he was treated or that it was a miracle. So if you see a Klinefelter guy with a pregnant woman, his wife, it's not his baby, okay? So no need to check the baby for Klinefelter problems and stuff like that. You understand the difference?
Can I ask about the Turner again? Like, because the Turner is donor egg, it's not from the mother DNA.
Yes, but
so isn't it still sterile?
No, because infertile, she makes a baby, like to make it, like give birth for it. So she's not passing down her genes, but she's passing, like she's becoming pregnant and having 9 months the baby and then giving birth. So infertility is when you can make the baby, you can become pregnant and you can give the baby.
Okay.
So I have an exercise here for you, okay? Just to consolidate it. For the first example, we have a healthy female. Her genetics are good, so it's not like Turner or something. And she has a very thick for sperm to pass cervical mucus. So the cervical mucus is very thick and the sperm cannot pass. Is she sterile or infertile?
Infertile.
Exactly, infertile. So what we can do is we can maybe do some IVF or try to do something on the mucus, and then the sperm can finally reach the destination and she can become pregnant. The second example, we have a healthy male. He has good genetics and he has low sperm count with bad mobility and bad morphology. You remember this from urology. So this guy, is he infertile or sterile?
Infertile as well.
Infertile. So we can take the sperm, select the ones that are looking very well, and then do IVF and implant it. Then we have a cancer female patient, good genetics, so the ovaries are fine, but that underwent total hysterectomy and oophorectomy for her cancer.
Sterile.
Sterile, exactly. There's no uterus. Removing the ovaries, okay, maybe you can find the donor egg, but she doesn't have uterus, so she's sterile. And then sexually active male who underwent bilateral vasectomy as contraception method. So he just cut his vas efferents and for contraception method. Is he sterile or infertile?
Infertile.
Infertile, yes. You can aspirate the sperm. Yes, so you understood the concept. Now we go on to precocious puberty, so pubertas precox. We have some terms here. Does any one of you want to try to explain what they are? Maybe starting with isosexual, heterosexual, maybe? It's the easiest. Sriram, you want to try? So isosexual?
I think isosexual is you end up developing the same sex that you're meant to be. Is it something like this?
So you are saying, like, remember your second year genetics. Phenotype follows genotype.
Mm-hmm.
Okay, yes. And heterosexual?
Phenotype doesn't follow genotype.
Exactly. So it's the opposite sex. Okay. What about true puberty and pseudo puberty? We said this in the previous lecture. You don't remember it? Okay. I'll just give you the definition. So true is when all secondary characteristics and mature gonads are there and the bone age is advanced. While pseudo puberty, you have the secondary characteristics, but immature gonads. So what you need for the gonads to mature is proper pulsatile stimulation of the entire axis from GnRH all the way down to the gonads. So if someone is having secondary characteristics, it's due to probably high estrogens or high androgens, but it was not properly stimulated from GnRH, LH, and FSH, so the gonads did not mature. So this is kind of like a peripheral, let's say, cause. While true, it's following the correct axis, let's say, so GnRH, LH, FSH, he gets his secondary characteristics due to finally making estrogens and androgens, but also the gonads are mature, okay? Isosexual, you said, and heterosexual, you said. We have heterosexual due to female virilization, so he becomes like a man, or male feminization, so he becomes like a woman, okay? And then we have complete and incomplete. So complete is when you have all secondary characteristics, and incomplete is when you have some secondary characteristics, so not all of them. So one, if you say one, isolated. If you say two, it's not isolated, but it is incomplete. If you have everything, it's complete. The thing with incomplete, you have to remember, is that the bone age must be within 1 year difference of chronological age. So this is another thing for bone age. So remember that young bone age is when it's younger than 2 standard deviations, and old bone age is when it's above 2 standard deviations of the age. But if it's within 1 year, then you can call it incomplete. Okay, so put it in the incomplete. We have the Turner scale here, the secondary characteristics. We talked about it last time. And then central and peripheral, you already met this in internal and also in third year pathology and pathophysiology. So central or gonadotropin independent is when the GnRH axis drives the changes. So it's always true. It's always true because it goes down, or everything is affected. So you have mature gonads, everything. So central is always true because it goes through the normodromic, orthodromic way of the axis. Peripheral is driven by estrogens and androgens. So it's a pseudo puberty. So immature gonads, the axis is not stimulating them. And it can also be iso or heterosexualis, depending on which hormone is there. So if it's a woman with higher estrogens, it would be isosexualis. If it's male with androgens, it's iso. And if you do the combination, then it's hetero. Okay, so that's the definitions. So do not confuse yourself. Again, we said timing and physical changes. This is delayed, means that, no, early, precocious, so it's younger than 2 standard deviations. You have different ages for males and females. Yeah, so from the mean, 2 standard deviations, some people say 2.5. So for females, this is the normal one, normal variation, to be younger. So the mean is 10 for females. If you're 8 to 9, you are still normal. But more than 2.5 standard deviations, that's females less than 8, males less than 9. This is your definition for pubertas precox, okay? So females less than 8, males less than 9, that's your pathology of early puberty. So definition, onset of first signs of puberty or secondary sexual characteristics at chronological age earlier than 2 standard deviations from middle age of puberty onset for gender. Okay? This one is more common in females. So an easy way to memorize this is that the girls get it younger, so they are also more common to get precocious puberty. And then the males get puberty later, so they're most common to get delayed puberty. Okay? And that's our blue line here. Any questions up to this point?
No.
Okay, moving on. Classification of precocious puberty. We said incomplete and complete. Okay, so incomplete, we have these different diseases. Menarche precox, don't mention it, it's very rare. But you should know thelarche, adrenarche, and pubarche, which are isolated. And we're going to discuss them now. And then complete can be central peripheral. We explained what is central and peripheral, but it's complete means all the secondary characteristics. So incomplete, we said that it's benign normal variants which have some secondary characteristics. If they have one secondary characteristic, we call it isolated. Gonads can be mature or not, depending if what is the reason, if it's true or pseudo, like what is the axis that makes the puberty. And then no bone age is advanced, so it's less than 1 year old difference, the chronological age from the bone age. And also the growth is normal. So then no treatment is needed. So for your incomplete, if you see someone who is having the precocious puberty and you do the bone age, if it's within 1 year, you say this is normal bone age and it can be isolated, so you just reassess it, okay? So linear growth is normal, bone age is normal, it's just a benign variant, no need for further testing, but you do some follow-up, okay? So reassess every 6 months, let's say. But if it's bigger than 1 year age difference, the bone age, you start to do more investigations. Okay for incomplete? And it's always isosexual. So, okay for incomplete? You understood what is?
Yes.
Okay, so you understood what is incomplete. Let's go to the specifics. So the thelarche and adrenarche and pubarche. So thelarche precox, we said that females less than 8 is pubertas precox. So it means that isolated premature breast development younger than 8 years old, because we have to be in the definition. Usually it happens in girls less than 2 years old due to mini puberty. We discussed mini puberty in the previous lecture, okay? Causes is basically something to do with estrogens. The estrogens are making the breast grow. So external or internal, or maybe the sensitivity. Okay, so some estrogens is causing the breast to grow. Diagnosis, we said absent of other secondary. So it's isolated, only the breast development. It can be uni or bilateral, but only the breast development. That's why it's isolated thelarche precox. Absent other secondary characteristics. If you have other secondary characteristics, then you jump to complete and you need to do more investigations. Okay, we said normal bone age within 1 year. So the growth and terminal height is unaffected. We're not scared of this. This is the second thing about puberty. We said first one is reproduction and maturation, but the second always terminal height. Remember this. These are the two problems of puberty. Treatment is not needed, but if it's older than 2 year old, we must investigate, or if there is dynamic change, rapid growth, or some progression. So it's usually less than 2 years old due to mini puberty. If it's older than that, then we have to do some additional testing. If the bone age is high, if they have more than one secondary sex characteristics, or velocity of height is becoming higher, find the cause for it, okay? So that's your thelarche precox. I will not spend more time on that. Now we have adrenarche and pubarche, and we know that adrenarche causes the pubarche. So we need to be able to differentiate them. Adrenarche, from the previous lecture, we said that the marker is dihydroepiandrosterone sulfate. Remember this? So this guy, isolated adrenarche precox, he will have high markers, while the pubarche will not have the high markers. So he doesn't have adrenarche, he just has the pubarche. So the differences is that, again, remember, absent of other secondary characteristics. So this is your incomplete definition, or beard, because beard, we said, is not by adrenarche, it's by testosterone, right? So adrenarche is only pubic hair and axillary hair, okay? So the difference between them two is the sulfate, dihydroepiandrosterone sulfate difference, and also adrenarche will have also the glands. Pubarche just the hair, but adrenarche also the glands. So this is your body odor, your acne, okay? So you have different smell and you have the acne, so your glands are changing. While pubarche just the hair. And you have the marker of adrenarche is normal. Everything else is normal. Normal bone age, normal androgens, everything is normal. Okay, understand the difference between these two? We said normal bone age within 1 year, isolated adrenarche or pubarche or thelarche, reassess every 3 to 6 months. No treatment. Okay? Okay, moving on to complete now. I want you to fill in the blanks. So we said that gonads to mature need proper pulsatile stimulation from which hormonal axis?
GnRH.
Exactly, from the top. And then true, you have the top axis, we said, is the same one. With, is it mature or immature gonads?
Immature.
The true puberty with the normal axis.
You mean true precocious puberty?
Yeah, so the gonads will be mature or immature in true puberty?
Mature.
Mature, exactly. So if we have the axis, the gonads can mature. So the true is based on the axis, so it's mature. The pseudo puberty is based on which hormones?
Testosterone and estrogen.
Estrogen,
Okay.
yes, estrogen and androgens. So the gonads are mature or immature?
Immature.
Exactly. So remember this, okay? Remember this. Don't confuse yourselves. Complete. We said it's complete. All secondary characteristics, not the incomplete. So it's not just the breast. It's not just the adrenarche. It's not just the puberty. It's all the secondary characteristics, okay? But the gonads can be mature or not, depending what is the cause. If it's due to estrogens, the gonads will be immature. If it's due to GnRH, the gonads are mature, okay? So we said this, and again, revision, gonads to mature, true and pseudo, okay? So sex hormones suppress the axis, so immature. The GnRH problem, the true puberty, it will make LH, FSH, so the mature gonads, okay? So central and peripheral. Again, puberty, terminal height, what we are scared of. If you have complete precocious puberty, we are scared also for terminal height, okay? Remember, when you talk about puberty, it's not just the physical maturation, also terminal height. This is the second big problem we have to solve. Complete central. So central, we said, is the axis activated, make LH, FSH more often in girls, and usually in girls, it's idiopathic, okay? So what does this mean? It means that if you have a complete central male, it's most commonly pathological, and we have to search for a brain tumor. And this is what they will ask in the exam. They will ask you to exclude some craniopharyngioma in a male who has precocious puberty. Remember this, okay? SOS. Precocious puberty male, it's very rare. We said it's more often in girls. If you see this rare case, check for brain tumor. Okay, central. So it means it's in the brain, the problem, central. If it's female, you're gonna see this often because we said that the girls, they start puberty earlier, so they're more common in precocious, while delayed is more commonly men. 80% are idiopathic, so no need to be scared for girls, but for males, you need to be scared, okay? We said we're gonna check the FSH-LH, the estrogens, testosterones. They will be in pubertal levels. Why? Because they already have the symptoms. So they already have the precocious puberty, they already have the signs. So these will be high in pubertal levels. But the patient is actually pre-pubertal. He's younger than 9 if he's a boy and younger than 8 if it's a girl. But her levels of FSH, LH, and estrogens, testosterones, they will be within the pubertal levels. So then we go to GnRH stimulation. And then what we're going to find in GnRH stimulation, if it's central or peripheral. So here, the axis is stimulated. So if we put even more stimulation, it's going to increase the LH. So it's central. For peripheral, the sex hormones block the axis, and our agonist, our GnRH agonist, is not so strong to overcome the negative feedback. So if I put my stimulation test and it doesn't grow, the LH, it doesn't go up, then I can say it's peripheral because the sex hormones are too strong and they are suppressing my agonist. You understand how to interpret it, the stimulation test, GnRH, central versus peripheral?
Yes.
Okay, good. So estrogens and testosterone, they have negative feedback on the axis, and my agonist is not so strong. So if it doesn't go up, it's peripheral. If it goes up, it's central. And symptoms, we said isosexual always because it's a normal axis. It's complete and true, so it's normal axis, mature gonads, and yeah, it will lead to less total height. So we need to treat it. This is not just like some disease you just look at and you monitor. You need to treat it. Etiology, most common cause is idiopathic, as it's most common in girls, and most girls have this idiopathic. So then this one, we're not scared so much. We don't do anything. We just confirm the diagnosis. While if it's a boy, we think of the CNS problems. And Dr. Rishi said that in his exam, they asked him to exclude craniopharyngioma in boys with precocious puberty. So remember this, okay? Can come up in your exams. So if it's precocious puberty male, always look for CNS. It's most common to have CNS problem. If it's female, it's idiopathic, okay? Treatment, it's central. So it's at the beginning of axis. So what we need to do is block the axis at the beginning. And we said that if you have continuous stimulation of the pituitary gonadotrophs, they would be desensitized. So what we do is we use a long-acting GnRH analog. You give a lot of GnRH, and then the pituitary will say, okay, I have to stop to do LH-FSH. And this prevents the premature growth plate fusion and short stature. So we save the height, okay? And then at the point, we stop the treatment to make them grow, okay? So it depends if you are male or female. We have 12 or 13 to stop the treatment so they can actually enter puberty. So we will not block the puberty forever. At the point, we need to stop the treatment. If you find some cause like tumor or whatever, then you treat the underlying cause. So that's our central, and we go to peripheral. We already said what is peripheral, and then it's driven by testosterone and estradiol. So the sex hormones, they suppress our axis. So if we do GnRH stimulation, there is no increase in LH because the negative feedback is too strong for our agonist, okay? And it would be the whole axis before will be low because of the low because of the negative feedback. Okay. Symptoms: immature gonads. Remember that gonads to mature need proper stimulation of the axis. Sex hormones, they make all secondary characteristics, but do not make the gonads mature. Okay, for peripheral?
Yes.
Okay. Etiology: androgens, some diseases, estrogens, some diseases, and remember also your beta HCG, okay? In boys, it acts as LH and TSH. Basically, you know that it's analog. So look for some tumors that they make this. And also it could be exogenous or endogenous. So androgens, estrogens, something that mimics LH and TSH, and exogenous and endogenous, okay? So easy way to classify them. And the treatment for peripheral: remove the cause. If it's possible, remove the cause. If it's not possible, remove the effect. And we have here from up-to-date diagram. You can block it at different levels. So just know the category of the drugs and maybe one example. Okay, so cause or effect. So the sex hormones must either stop production or stop the effect. So that's easy treatment. And now let's go to a summary of diagnosis. So we said history. We have all of these things we discussed. Physical examination, we discussed everything. Tanner, don't forget to Tanner scale. So centiles, physical examination, Tanner scale, history. Then for bloods, important labs, we said testosterone, estradiol. These are not so helpful because they will be high anyway. If you have someone with precocious puberty and you see secondary sexual characteristics, how did these characteristics develop? So they would be high anyway, but what will change is the LH-FSH. So these are most important, okay? If it's LH is high, you say it's coming centrally. So it's from the upstream from the axis. If they are low, then it can be actually normal, so at the normal level, or it's some peripheral pseudopuberty, so some sex hormones suppressing the axis. So this you can easily understand. We discussed it already. Maybe if you have some indication for another disease, you can do like other tests. We talk about adrenal here. And then a dynamic test, we need to check central versus peripheral. We said that if you do a dynamic test for peripheral, the negative feedback is so strong that the LH is still suppressed with our agonist, so no change there. But if it's central, it will actually be stimulated. Okay. Okay, mini puberty. And then you have some other tests like synactin test, that's for your adrenals, dexamethasone suppression test, again for adrenals. And this is the diagram from AMBOS. They have a new diagram now, so you can look at the new diagram. Yeah, imaging, bone age. Remember that for incomplete is less than 1 year difference. If it's more than 1 year difference, you go to more investigations. So this is from Ambos. If it's within 1 year, it's isolated, you just reassess it. If it's more than 1 year, you follow the tree, okay, of Ambos. That's how your bone age, you do it with the left hand X-ray. CNS MRI, try to find some tumor in the brain. Ultrasound, check your adrenals, genitals, internal genitals, gonads. May use CT if you want it, and then bone scan in specific diseases. Okay, so we have imaging as well, and then summary of the treatment. Find the cause, severity, early treatment. So also the development, but also the terminal height. Don't forget terminal height. Okay, especially endocrinologists like to ask what is the 2 problems we have to solve in puberty. If it's incomplete, we know that they have 1 year difference, no treatment, just follow them. And then for complete, we have central versus peripheral. We discussed the central, long agonist for general age. And if it's peripheral, either remove the course or remove the effect. Okay? Select the diseases, idiopathic, most common. This is a central type in females. Then the CNS tumors, that's central for boys. Something in periphery, adrenals or testicular or ovarian tumors. Congenital adrenal hyperplasia, you will know it anyway very well for other questions. And Noonan syndrome, they like to discuss in the lecture. And McCune-Albright is like just basics for these two, a few bullet points, and focus on saying this, okay? Any question for precocious puberty?
I have a
Yeah.
question.
Okay,
Like,
yes.
I understand what you're saying, but how the patient come to you will look like, because even sometimes if we have precaution puberty, parents feel it's normal, so no one go check up. So if it's they check up in later age, do they change anything? Like, I
You
mean,
said precocious puberty or delayed?
precaution, not the delay one.
Okay, so precocious, they are normal. What do you mean normal?
Like, I mean, they're just 1 year earlier. As you will say, is incomplete, and complete is more than 1 year earlier.
We're
So,
talking about bone age, right? So bone age, only bone age.
so how
So
do
that's
you
bone
know?
age. If you look at here, you have someone who comes younger than 8 years old female or younger than 9-year-old male with secondary sexual characteristics. So you do the hand X-ray to find
They
the
just
bone age.
so they just
Then
come to you, like, because sometimes we feel it's normal, more like to
uh,
have 1 year earlier. So
no, it's not normal to have like a male with enlarged testicles and enlarged penis and then hair and some few
so all
beards
okay,
at let's say 7 years old,
okay, so that is not normal.
because the first sign for puberty in males is testicular volume. Then the first sign for females is breast, like sothelarchy. So it's not normal for a 6-year-old girl to have big breasts and then start also to get a few of pubic hair and like, you know what I mean? So they come to you as I hit puberty early.
Okay, so like all the characteristic already developed before the age. Okay,
Not all of them, but the onset. So if you go to the definition of precocious puberty, is onset of first signs. So this is like breast, voice, hair, beard, muscle, fat, everything we discussed in the first lecture at chronological age younger. Okay, so female less than 8 with the first signs of puberty, or male less than 9 with the first signs of puberty. And we said that the first sign of puberty is testicular volume growth in males, and then in females is growth plus thelarchy. So if you see a 6-year-old female who is growing fast with big breasts, that's precocious puberty.
Okay.
So that's the blue one, you see? Like they come at 8 or 9 here, 8 years old, and they, okay, that age is wrong. But yeah, they come and they grow fast, while actually the growth should happen later, the black line. This is the normal, black. But they grow with the blue. Everyone else in their class is stable, growing slowly, but they are growing super fast. So we need to stop this, because if they keep growing super fast, they will stop to grow, and then they will have low height.
Okay, I understand.
Okay. Any other questions? I'm here for your questions. Any other questions?
No, it's fine. Thank you.
Okay, sex development. Now we're gonna do only physiology. I forgot to change that. Only physiology. Okay, it will be fast. It's a revision from embryology and second year and first year. Okay, so for this question, what they like to focus on is congenital adrenal hyperplasia and Turner. So Turner, you know it very well anyway from puberty. That's why you see some diseases repeat themselves. Congenital adrenal hyperplasia is here the most important though, and you need to know it very well. It's also important in screening. Okay, so when we discuss the disease in sex differentiation and we say congenital adrenal hyperplasia, we have to remember that it's also a screening question disease. So we have to mention about the screenings. Okay, so congenital adrenal hyperplasia and Turner are very big topics. Like we have to know them very well. So on the next lecture with pathology, I'm going to spend more time on them and say everything, including pathologies, screenings. So all the symptoms, we're going to do them later. So now we will focus on physiology, okay? Other diseases, just know this is just the basics, what they mean, so you are not lost. So in order to understand this, and because we're doing understanding right now, we're not doing memorization. To understand this, first we need to do some terminology, okay? So definitions. Do you know these words? Have you seen them before? Can you try to explain maybe what they are? Because this is the terminology we will use to explain all the diseases in sex development. Does someone want to try? Any words you know? You don't have to do all of them, just the ones you know.
Okay, ambiguous genitalia. That's like when you're unclear of the genitals, right?
Okay.
Yeah.
Anything else?
Chimerism or mosaicism is to do with the cells itself. Like you have, okay, I don't remember it extremely well, but
What do they have in common?
they have different chromosome patterns in
Exactly,
cells, right?
different DNA. So it will be
Yeah.
the same, like in one organism, you have two sets of different DNA. It's like having
Yeah.
two people in one.
Exactly.
Okay, something else? Maybe this for internal?
Yes, virilization is when you have no, so hirsutism is when you have male characteristics, and virilization is when you have female characteristics in men. Yeah. Right.
No.
That's the opposite.
No. Okay, let's go through them together. Okay, let's go
Okay.
through them together. So disorders of sexual development, that's DSD. It means disorders of sexual development, DSD. So ambiguous genitalia, as you said, they are same as atypical genital appearance or zwitterionic genitalia. Is when the external genitalia do not have some typical male or female. You don't know what it is. So in pediatrics, we use Prater virilization scale. Okay, this scale is what we use, not Prader-Willi. Okay, just Prater. Prater virilization scale. Don't confuse yourself. It's from 0 to 6, and as you can see, it's normal. So 0 is normal female, 6 is normal male. Okay, so someone who is normal male, he will get a score of 6. Someone who is normal female, he will get a score of 0. Anything in between, 1 to 5, it's considered like ambiguous genitalia. Okay, so somewhere here. DSD is congenital conditions where development of chromosomal, gonadal, or anatomical sex is atypical. So you have to say these three categories: DNA, gonads, and then the phenotype. So malformation of external genitalia is usually accompanied by more congenital malformations. Okay, so it's not just external genitalia. So this is what we see. So we can use this, the external genitalia, as an indication of doing further diagnosis and finding more congenital malformations. So that's the first terms. Chimerism, mosaicism. So what they have in common is that they both end with two DNA in different cells in one organism. Chimerism is when you have two zygotes, and mosaicism is when you have one zygote. Okay, so that's our term. They both end like this: one organism, with two different DNA in its in different cells. Gonadal dysgenesis, that's your pathology from third year, is when during embryogenesis you have underdevelopment of the gonads. Okay, they have various phenotypes, various degrees. But what is important to know is that they cause strict gonads with fibrous tissue. Okay, so it means that they are infertile. They have delayed puberty, so the gonads will not make the puberty. And also, the strict gonads are high risk for malignancy. What will happen first is that they will get gonadoblastoma, which is benign, but this one can convert to the malignant dysgerminoma or seminoma, so it's the same tumor, depending on gender. So that's why we need to remove them, okay? If you see strict gonads, remove them. They are high risk for malignancy. Maybe you did it in oncology. Then how to classify the dysgenesis? We can classify it as complete, incomplete, or mixed. So complete or pure is when you have complete loss of gonadal function. So the entire gonad is dysgenetic. If we have XY, so that's the male, you can also call it Sawyer syndrome. Okay, so Sawyer syndrome, XY sex reversal is the same term. In females, you just say XX man or XX sex reversal. Okay, sex reversal, we said when the phenotype is complete and also opposite of karyotype. So if you go to incomplete or mixed, is no longer sex reversal. Okay, so only Sawyer syndrome and XX man are considered sex reversal, and they are complete loss of the gonadal function. What else can happen is that during embryogenesis, only partial gonad is lost. This is incomplete, and this will cause various phenotypes. Okay, they look like this, the gonads, this genetic. And then mixed is when you have like mixed, so different. Each side is different. So for example, one side is testis with the Wolffian structure, so that's your vas deferens, and then on the other side you have strict gonad with Mullerian structure, so that's your ovarian tube, the fallopian tube. Yeah, so this is mixed. If it's not mixed, it can be incomplete or complete. Okay with gonadal dysgenesis?
Okay, yeah.
Okay, good. Then we go to clitoromegaly and micropenis. We said pediatrics, the size of the penis, size of clitoris, they keep changing over time. So we use standard deviation, more than 2 standard deviations from the mean. Okay, just use standard deviations. Done with the definition for the size. Then cryptorchidism, it's failure of testicular descent. Okay, so the gonad, it can be either testis or ovotestis. Why testis? Because the testis is responsible for making the descent. So the ovary will not try to descend, but the testis and ovotestis will try to descend. And you find them in various positions. It can be true. True means follow the normal course, or ectopic. It means that it didn't follow the normal course. It's somewhere else. Okay, so that's cryptorchidism. If it's symmetrical, like both sides, it means that some systemic hormones did the effect. It's due to some systemic hormones. So both of them are affected by some systemic hormones. While if it's asymmetrical, like it means that you have different gonads on each side. So it means that one side you have testes, which normally went down, and on the other side you have ovotestis, which came like halfway. Or maybe it's abdominal, like it didn't even come here. Or ovary and testis, you have asymmetry. So it means that you have different gonads. If it's symmetrical, it means that something systemic caused the cryptorchidism. Remember, for any cryptorchidism, you have risk for testicular cancer. And also, the reason why the testis goes down is that you need lower temperature for spermatogenesis. So high temperature will kill the sperm, so low sperm count. And then most will spontaneously descend after birth. Otherwise, we do some surgery to fix it. Okay. Remember that in preterms, it's okay to have a bit of cryptorchidism until 34 weeks. They start to descend about 34 weeks. They should be complete. Okay. So if you have some preterm 32 weeks and you don't see the testis, it's normal. You don't need to do surgery. You just need to wait. Okay. Remember your preterms. Hermaphrodite. Hermes and Aphrodite, so male and female. Virus means true in Latin. So it means that the gonads are both female and male. So it's true hermaphrodite, male and female. Pseudohermaphrodite means that the gonads are only one type. So both, let's say, ovaries or both testes, but the genitalia are atypical. So it's not a hermaphrodite, it's a pseudo-hermaphrodite when the genitalia are atypical. Yeah, intersex, we don't use it so much. Hirsutism, H for hirsutism means male hair in women. That's good for your internal exam as well, Sriram. H, okay, hair. So they look like male, thick, dark hair, but also they are found on different positions, like back, on the back, yeah, on the mouth, like beard. So we have a classification, a scale. We have a grading scale for it. So location and type, they are androgenic location, androgenic type. So hirsutism is hair. Virilization in internal, in adulthood, you are talking about secondary characteristics. So that's your deep voice, muscles, hair growth. But in pediatrics, when we say virilization, we are talking in the neonate for external genitalia to become male. You remember your Prader stage? The further right you go, the more virilization happens. Okay, so virilization pediatrics, we're talking about external genitalia. In internal, we're talking about, because they're already adults, they're already after puberty, we're talking about secondary sexual characteristics. Their genitals are already formed after puberty. So if they're normal after puberty and they get virilization, then we talk about secondary characteristics. But the children, they are now developing, so the newborn, we talk about external genitalia. Remember that the only thing needed for external genitalia maturation is testosterone and dihydrotestosterone. These two things. So if you have absence of this, you become female. If you have a lot of estrogens, they will not be affected. If you have a lot of testosterone or dihydrotestosterone, they will be affected. Okay, so the determining factor for genitalia, if it's going to be female or male, is only androgens. Okay, so when you see external genitalia, it's like a marker for androgens. Just know that this is important. They ask in the exam. And virilization is 3 steps. Okay, we're going to talk about them later. If the 3 steps go bad, you end up with the hypospadias, epispadias, okay, or some problems with the virilization here. And also virilization term can be used to classify pathophysiology. For example, hypervirilized female or hypovirilized male. So you can use it also for pathophys, this term. But don't forget, hirsutism is hair. Okay. Ovotestis looks like this. Okay. It's when the gonad has both tissues of ovary and testis, and they can have different percent compositions. Okay. Yeah. So this is ovary and this is testis, but this is one organ. It's one gonad. So remember that ovotestis cannot make spermatogenesis. You need 100% testis to make spermatogenesis. And then we can have different combinations, like ovotestis, bilateral or unilateral, testis and ovary, or ovotestis and ovary. So you can have different combinations, okay? Usually, if you have ovotestis, they are going to have fallopian tube. Ovary is longer for making and the testis go away. So if you have ovotestis, usually you have fallopian tube. 30% may have difference. Okay, so that's your ovotestis. It's a gonad which now this is going to secrete testosterone and it's going to make the descent. Okay, depending on the percentage composition, it will tell you where it is found, how much descended. 50% of ovotestis remain in the abdomen. 25 get stuck in inguinal. The testis is not producing enough hormones to make the full descent, and then 25% are found in the last position. So how much testosterone is created by testis tissue is responsible for making the unilateral gonad go down. Okay, so descent depends on the gonad itself. So each gonad is responsible for its own descent. If you have a testis plus ovotestis, the testis will go down, but the ovotestis will be cryptorchidism.
So ovotestis only happen in male, right?
It could happen in both gender. It's just problem with development. I think that yes, it should happen only in men because they have the Y SRY, or it could happen in women who have SRY jumped over to the X chromosome. So these cells, they have the Y chromosome, these cells, they have the X chromosome. So not the chromosome, the SRY region, basically. They have the SRY region, maybe it's an X with an SRY region, and this one is like a Y without SRY region. We don't know. So it can be both, I think. Not 100% sure, but I think it could be both, depending on how this genesis happened.
Okay.
But to have testis here, it means SRY region somehow ended up here. Either the whole Y chromosome or the SRY jumped over to the X. Streak gonads. Okay, streak gonads, they are severely dysgenetic gonads, cannot be identified as testis or ovary or ovotestis. They are just dysgenetic, okay? And they are not functional. So it's complete. They are linear. You look at this white one here, they are linear. This is what they call streak gonads because they are linear. And they're also fibrous. So there's no germ cells, there is no hormones, there is no like follicles created. So they are infertile. Yeah, if it's severe, maybe a hypoplastic uterus, etc. What is important is that we said it before, the streak gonads are a risk factor for malignancy. We need to take them out. Gonadoblastomas are benign, but then they can jump to dysgerminomas, which is malignant. So streak ovaries, they're found, for example, in Turner. For Turner syndrome, they will ask in the exam the most severe form. Okay, so you need to say all the severe things. But in real life, most of them are mosaics. We explain what is mosaic. So the gonadal involvement is less. So in real life, you will not see streak gonads a lot and like all these huge dysgenesis. But in the exam, they want to know the most severe form. Okay, so when we say Turner syndrome, always think the most severe form, even though it's rare in real life. Testicular regression is also called vanishing testes syndrome or congenital anorchia. It means that the external genitalia are male, virilization happened normally, but now no testes can be found. Okay, so during fetal development, there was Leydig Sertoli, they make everything happen, virilization is okay, internal organs are okay, external organs are okay, but for some reason, they disappeared, they died. Mostly it's unknown reason, maybe bilateral testicular torsion, and then they died. But what is important to say is that if you have testicular regression, it means that no testis can be found anywhere, not in the scrotum or somewhere else, not in abdomen. So it's called anorchia. While cryptorchidis, you can actually find the testis, okay? You can actually find the gonad. It's somewhere in the body, but it's not in the right place. So it's cryptorchidis. Anorchia means cannot be found. It disappeared. Vanishing testes syndrome, okay? And then because there's no testes, so when it's born, the baby, it finished the virilization, it looks male, but then he has problem with mini puberty and puberty because there is no gonadal, there's no gonads there. So that's testicular regression. MIS, so anti-mullerian hormone, also called MIS. Do you know what is MIS, maybe?
No idea. Sorry.
Mullerian
Oh,
inhibitory
okay.
factor. Okay, so it's also called MIS. If you see MIS, Mullerian inhibitory factor, in some books when you revise, just know it's the same as anti-mullerian hormone, okay? So this is your basic first year things. Chromosomal sex, you have the SRY region. This is very important. It can jump to an X. It's gonadal determination. We have bipotential gonadal differentiation, either ovary or testis. So depending on which genes they get, they can become testis or ovary. You can see here, the female can only give X, while the male can give X or Y. Okay. Yeah. What is controlling the external genitalia is the androgens. Okay. Without them, the female sex develops. So remember your androgens. And this is important for the 5-alpha reductase deficiency. 5-alpha reductase is responsible for converting testosterone to the more potent dihydrotestosterone. Okay. And why is this important? In this disease, we have problem of the red structures. We have a lot of testosterone, but not dihydrotestosterone. So 3 things: phallus, scrotum, and prostate. They do not form in 5-alpha reductase. We have testosterone, but not dihydrotestosterone. So I think this was not in first year, but you should know that both of them are important. And dihydrotestosterone is responsible for phallus, scrotum, and prostate. Estrogens are responsible for secondary sex characteristics, so they come back in puberty, okay? While the actual differentiation in the beginning is androgens. Okay, a small exercise. Can you tell me the female here? Like testis becomes in female, what are the homologs?
Ovary.
Ovary, penis becomes
Clitoris.
clitoris, scrotum becomes labia.
Labia, yeah.
Which one?
Majoris.
Majora, spongy urethra, labia minora. Foreskin becomes the clitoral hood, and I want you to tell me what bladder becomes in females.
It's the bladder, yeah. It's the bladder.
Bladder.
Same.
And urethra in females?
Same. It's urethra.
So urethra and lower vagina. Okay, so urogenital sinus is going to make lower vagina in females. Remember this. Okay, it's the only big difference. So where does the upper vagina come from?
Cervix or uterus.
Yeah, good. So it's the Mullerian structures.
Okay.
So this is your embryology. So the red one is Mullerian structures and the yellow is urogenital sinus. And then when they grow, the upper third of the vagina is made of Mullerian structures. So the Mullerian structures. And then they will go to inguinal lymph nodes. They're made of columnar cells. And then the urogenital sinus goes to iliac lymph nodes and they're made of squamous cells. Okay. And this is important for your gynecology as well, that here, this part is made from the Mullerian structure. So it's columnar, right? But it has to become non-keratinizing squamous epithelium. This happens because vagina is acidic and the endocervix, the columnar cells cannot handle it, and then they change to squamous. This is called metaplasia, remember, for third year. And metaplasia is like a risk factor for tumors, right? So it's like transformation zone. You can see here, the columnar becomes squamous. Transformation zone, that's the problem where we have a lot of cancers. And also they have different lymph nodes, okay? Why is it important in sex development is that if, imagine that this red does not exist, but the yellow exists, how will the female patient look like if I put my finger inside?
The external genitalia will be normal, right?
Yes, and the vagina will be normal as well. So if I put my finger inside the vagina, what I will touch? There is no cervix, there is no upper vagina.
Uh,
The outer part of the rectum.
No, so basically this yellow thing over here, you see that it's closed? It will
Okay.
remain closed. So it's
okay.
called blind-ended vagina or pouch-ended vagina. So when you study for your disorders, if you have some problem with Mullerian structures and the female develops normally with the vagina, then you put your finger or something, then this would be closed. You are going to feel instead of cervix, or when you put your speculum, you will not see cervix, you will see the vagina just closing, like a one way, like and like a dead end. So remember this, especially for gynecology, that the vagina can be there. You can put your finger or speculum or whatever, but when you open it, you don't see cervix. You see still vagina, and it's like a wall, okay? And then you do the ultrasound and you see that there is no uterus, and then you find the other congenital problems. So know that this is important, the different embryology, okay? So what I use for revision, like videos from Osmosis and Mitchell ICT, illustrated color text, is very good summarized. This is perfect for clinical. You don't need all the details like histology. So just look at the video, maybe look some images here, and then you get the basic idea. So we said there is 3 steps, important steps for external genital virilization. So how does this become male? What are the 3 steps you need to know for virilization? Okay, I'll give it to you.
Okay.
So labioscrotal falls fusion. So this one needs to fuse. Okay, labioscrotal fusion. Phallus elongation, you need to become big. Okay, so it's not, doesn't look like clitoris, it looks like a phallus, like a penis. And then the urethral meatus to be on the top. Okay, so the urethral meatus goes up, and goes on the top. Otherwise, you have like the hypospadias and epispadias, right? So this is osmosis, this is the book, this is the female, how the female is not virilized. Then go internal organs, internal genitals. Okay, let's talk about internal genitals. You remember that you have the kidney and the urogenital, let's say, development. So it's uro and genital. First, you have pronephros, just a temporary structure. Then you go down, you have mesonephros. So this will be your male, okay? Wolffian duct comes from mesonephros, this blue thing here, the mesonephros. So in the beginning, mesonephros is going to develop the kidneys as well, but then they will separate. And the urogenital will become uro and then genital, so two different systems, okay? So how it will look like is that you have the mesonephros, and then it's going to induce the first creation of the kidney. So that's the blue thing, mesonephros. But then they split. So the blue is no longer here. This continues on as a urinary tract development, and then the ascent of kidneys to meet the adrenals. That's your metanephros, okay? So permanent kidney and ureter, this one here, metanephros, will detach from the blue. They will detach from the blue, and they will go up, and they will make the urinary tract. And then the blue one here, it will stay. It will stay as a Wolffian duct. Now, where does the female come? The Mullerian is basically the pink one. It's by itself. It's paramesonephros, only for females. Has nothing to do with the urinary tract, okay? So the blue one is the Wolffian mesonephros, which is going to become male after detaching the kidney, okay? And then for females, they have nothing to do with the urinary tract. They are just sitting there. They are paramesonephros, so they are sitting next to the mesonephros, Mullerian duct. Easy to remember this. This is all you need to know for embryology, nothing more. Okay, now I want you to tell me how the gonads form, the testes and ovaries. Where do the primordial germ cells migrate from to? Do you remember, or shall I tell you the answer?
I have no idea.
Okay, so it's basically the yolk sac. So you have the yolk sac, and they migrate all the way to the urogenital ridge before they split. But after they split, they become genital ridge. So genital ridge has here the gonadal genital ridge. So this is from mesonephros. So it goes from yolk sac and goes to mesonephros. So the primordial germ cells come from the yolk sac. Okay, just a quick revision. And then we have the Wolffian duct. How I remember it is that men are wolves and females are mules and cute. So yeah, mules and wolves, easier to remember that men are strong and wolves. So yeah, so that's the blue one we were discussing before. It will go on and it will develop into the testis, while the paramesonephric duct, you see that the blue one disappears, it degenerates, and then the paramesonephric duct remains and becomes an ovary. Okay, so my question to you is the internal genitalia, 3 female and 3 male. So Wolffian duct becomes 3 male structures and Mullerian duct becomes 3 female structures. So which structures are created? I want 6 structures.
Testis, epididymis.
Testis is a gonad.
True, yeah. Okay.
So
epididymis, yeah.
yes, and then you are right. Okay, so seminiferous tubulus vesicles is the kidney, then epididymis is next to it, and then vas deferens is the tube. And then for females, fallopian tube, uterus, and upper third of vagina. So remember upper third of vagina, okay? So upper third of vagina comes from here. So any problems in Mullerian structure, we have blind-ended vagina, okay? And then we have to do some treatment for it maybe. And then we said this, that the testis for descent is homolateral gonad androgen levels. We said this already, and that we also care for the dihydrotestosterone for the phallus, scrotum, and prostate, important for 5A reductase deficiency. This is just the cells. Leydig is responsible for the androgens, and Sertoli is responsible for anti-Mullerian hormone, which is going to make Mullerian duct go away and Wolffian duct developed. And then Leydig, we said testosterone, so everything else for development of external, okay? So external and dihydrotestosterone, both of them are important, testosterone and dihydrotestosterone. Testosterone, we said, pituitaries, vas deferens, seminal vesicle, so that's your blue thing. And then dihydrotestosterone, that's everything else. So that's phallus, scrotum, and prostate. Okay, remember that they have different structures, the androgens. They are specific. This is important for your 5A reductase disease. And also important is that when you have problem of secretion or the receptor, they will be the same. So testosterone DHT secretion or testosterone receptor problem, they will have the same phenotype. So either the testosterone or the receptor, either the dihydrotestosterone or the receptor, they will have the same thing, okay? So androgen sensitivity, AMH sensitivity, it's as if the cells are not there, okay? So we are talking about endocrinology, so hormones is the signal, and then you need the receptor as well, not just the signal, not just the receptor, so both of them. These people, we said, the axis, adrenarche and growth hormone is okay. The problem will be gonadal mini puberty and puberty, okay? They will ask you, does a problem of the gonads affect adrenarche or growth hormone in puberty? You will say no. The axis here is different than the other ones, okay? We said this already in the previous lecture. And this is just the final slide. It's just a quick review and all the sensitivity problems or Sertoli problems and Leydig problems, everything we just discussed as a quick summary, okay? Any questions?